welcome everybody. Thanks for taking time out of your busy day for really excited to look forward to Bar's presentation about something that's increasingly important. I mean, we're in the middle of a heat wave now at many places of the country that have never experienced that. So I think it's a really relevant topic. And how does this impact health? So welcome. And first, I'm going to turn it over to Linda. And Liz already explained about hold your questions to the end here.
Yeah, great. Thank you so much. Hi, everyone. Good to see you all. I hear there are about 15 to 20 people online at the beginning here, so maybe more too. So please, if you have questions from either virtual world or in the room, I'm just going to be going over some of our work on our educational mission. So I know everybody in the room, I think, but I'm Linda Montgomery. I'm the Vice Chair of Education. I've been with the Department of Family Medicine for 17 and a half years, all of that time as an educator and a family physician, and for the last year and a half in this role as Vice Chair of Education. So I've been asked here today to give you a very, very quick overview of our educational mission. We are going to be going over sort of our strategic plan and its place, education in the strategic plan. Our current programs will take up most of our time here together, and then some challenges I wanted to highlight, and then some opportunities, and then if we have any time for some questions. So to remind you, we are very much involved in our strategic plan right now. We have 5 key aims in our strategic plan in our department. And I would say education obviously is across all of these aims, right? I think we could probably agree on that. We have one that very much focuses on it, which is training. So I wanted to just put that in your mind as I start here. Under our training key aim, we have train a future integrated family medicine workforce. And that rolls into some goals and then some strategies around how to do that, having to do with leadership training and recruiting people into our work, and then enhancing current and launching new family medicine training programs. So just remember, as we reflect on what we're doing and what we might do, are we training a future integrated family medicine workforce? So I wanted to start here because I sometimes, when people say, well, the education in the department is about residency training, right? Or about undergraduate training, meaning medical students. And it's always surprising to me that we don't have a sort of holistic view of our training here within the Department of Family Medicine. So I wanted to do just a little baseline education about our educational programming. So we have 3 big buckets in education. We have medical student education. We have physician graduate medical education, which involves our residencies and our fellowships. And then we have interprofessional education. Some details about those areas. So our medical student education, we have a large, maybe not enough, but we have a pretty big footprint in the new TREC curriculum. We have a new curriculum in the School of Medicine called the TREC curriculum, and we have a fairly significant footprint in that curriculum where we have docs coaches, compass guides, and many, many of us family physicians are involved in the longitudinal integrated curriculum, which is a year-long experience in all the different disciplines. It's their basic clinical training, and many of us teach within that LIC. Then we have our, and this area of medical student education run by George Olson and Roberto Silva has a great group of faculty working to make sure that we are expanding our footprint in the TREC curriculum. Then we have our rural program. That's our 4-year longitudinal program for about 20 students per class. That's also housed in the DFM, led by Mark Deutschman and Roberto Silva, very well regarded in preparing medical students in various disciplines, not just family medicine. And then a little shout out to this group. 12.5% of our recent class went into family medicine. Of course, we understand that that's not absolutely meeting the needs of our communities and our nation, but it is 50% higher than the national average coming out of our other medical schools. Our residency, this is where I come from, so I could give a whole talk on the residency, but suffice it to say that we have a 3-year training program for 11 residents, so 33 total in any given year we're training, led by our very wonderful Corey Lyon, who you see here, the top picture there. It's nationally regarded with broad scope training, special expertise, I would say, in preparing for urban underserved care and academic careers. We have 2 tracks differentiated by the continuity clinics, and we have inpatient services at both Denver Health and University Hospital. A bit of a shout out here. I think that UCFMR really strives to be on the cutting edge of residency education. Those are some examples up in those bullets that I don't have time to go over now, but I really think that our residency program has for a long time, well before I got here, has tried to be on the cutting edge of what it means to be a 21st century family physician. And then the residency program has been a significant engine of faculty production over the years for the DFM, for University Hospital, for Denver Health. This is just a snippet from a photo, which I may or may not have stolen from someone's Instagram account, that shows you that the 3 people in the front are some of our most wonderful faculty in teaching our medical students and our residents right now. And then our rural residency track. This is part of our residency. It is a 3-year program of 2 residents per year. It's pretty young. It's only about, I don't know, Dan could tell us, 7 years old, perhaps. The first year of each of these residents' training is in Denver, and then their second and third years is in Fort Morgan. And of course, they are focused on training family physicians to work in rural Colorado and beyond. We also have residencies under the School of Public Health. So our occupational and environmental medicine residency and our preventive medicine residency, they have leaders within the School of Public Health, and the training occurs there. However, our DFM does provide program coordinators and guidance through my office. Now, onto our fellowships. Our addiction medicine. So we have 4 fellowships. Our first is our addiction medicine fellowship. There are 100, I read yesterday, 104 ACGME approved accredited addiction fellowships in the US. Ours is the only one in Colorado. And if you look at the map, there aren't very many between the coasts, and ours is one of them. It was established in 2015. The first grad of that program is actually the current program director and also a grad of our residency program, Kaylin Klee. It's a 1-year fellowship with 2 fellows per year. We also have our hospice and palliative medicine fellowship that has 2 different arms. The traditional track, long time, the first director, I believe, was David Knowles, pictured here. And it is a 1-year fellowship with 5 fellows. The leadership has been transferred to Kelly Arnett, also a graduate of the residency. And just recently, Kelly has become the leader here. They also have invented this community-based track, and this is a very inventive experimental model, training fellows in their home communities, very much needed by our country. So it's a 2-year program and up to 12 fellows per year. Then our sports medicine fellowship, led by Jack Spittler. It is a 1-year program, training 4 fellows in these separate tracks that you can see listed on the slide. Very well-regarded program, one of the most sought-after programs in the country in sports medicine. Finally, our junior faculty fellowship, it's a 1-year program, usually 2 fellows, established in 2012. It has trained 25 fellows so far. They pick a passion area and then train in that. We create a fellowship for them, and they work as attendings on our inpatient and in our clinics as well. I threw up some of the pictures of some of our grads. I'm so proud of them. As you can see, it has created some of our most notable current and emerging leaders in our Department of Family Medicine. And this year's fellows are in disability medicine and in climate health. So nice synergy with what Bar's going to present to us in a few minutes. And then interprofessional education. We have, this is very important, I think, in family medicine. We work in teams in family medicine. So we also have a training programs in psychology led by Sandra Brown-Levy with externships, internships, and fellowships. We also help to train our primary care pharmacologists with 1-year training through the School of Pharmacy. They do longitudinal work at A.F. Williams. And honestly, on any given day when I'm in the preceptor room, I sometimes feel like I'm co-training these folks as well. We do a lot of, they teach me so much, and hopefully I teach them something too. Just a few notes on challenges and opportunities. There are major challenges, I think, in DFM education. There is reduced interest in family medicine nationally and locally. That's a very busy slide up there. You get the trend, however. This is showing the percentage of the blue bar is the U.S. MD graduating classes matching in family medicine, and then the percentage of University of Colorado is in red. So even though the national average is 8%, it was 8% last year, ours was 12.5, but you can see the trend is not wholly reassuring. We've also had cuts in our general appropriations funding, and we've been working with great intention on what to do about that. We have a new curriculum in the track curriculum. We have a new dean, so there's a lot of newness out there that is a challenge. And just recently, Dan Burke wanted me to mention what he considers an existential crisis. We're having problems with our faculty recruitment and retention in rural Fort Morgan. Opportunities, innovations are much greater than I can cover here. I would just want to mention a few of them. All that busyness up there is the newness of the track curriculum. In that newness also comes the opportunity to do more within the curriculum. So our wonderful faculty in medical student education are working to expand electives within the track curriculum. We have residency redesign happening in our own residency. We have the opportunity for expansion of current programs. I would say that every fellowship director has approached me with, can I expand? How do I do that? I could do that. Where does the money come from? We also are interested in creating new programs. The most notable up there is Highlands Ranch Hospital. Brad Winslow, who joins us here today, and I are working on a pro forma right now about how do we create new programming. There'll be more about that and other new programs coming your way. We're also working on the expansion of educational scholarship across our MSc and GME groups, and expansion of faculty mentorship. So a lot of things going on in education. So I just bring it back to ask you, are we training a future integrated family medicine workforce? And what could we do to better do that in the future together? Okay, that's my overview. Any questions? Thank you, Jody. Any questions that y'all have? Yes. Oh, yes, that would be me. Please do. Linda Montgomery, linda.montgomery@cuanschutz.edu. Please let me know if you'd like to teach. We'll make sure that you get to do that. Okay. Not online. Okay, well, thank you. If you do have any, please email me, text me. Many of you, my number's right at the bottom of my signature block. Get in touch with me. I'd love to talk about things. All right, I'm going to pass it over to Bar.
All right. So I see some familiar faces, but I think for probably a good amount of the department, I might be a newer face, or maybe you've heard my name, but you don't know me personally. So I thought today I would give you all just a really high level overview of where I'm coming from in terms of working in the climate and health space, and also straddling really my work both in the Department of Family Medicine, but also in the Climate and Health Program, which is housed at the School of Medicine. Give you an understanding of why we're doing what we're doing, what we're working on, and then hopefully we can have a little bit of engagement to think about what are some future directions and how we can, speaking of preparing a family medicine workforce for a climate resilient future. So a little bit about me. I actually did the Climate and Health Science Policy Fellowship in just out of residency in 2021, I think, and then joined as faculty. And now I direct both the fellowship and also a program called the Diploma in Climate Medicine, which I'm happy to chat a little bit about what that is at the end. I have some objectives because you should always have some objectives. But to start off, I think, increasingly, I don't have to make this point anymore. I think we're seeing what this looks like. But this is actually from 2008 or 2009 from the Lancet, where they really sort of highlighted climate change as being one of the biggest global health threats of the 21st century, if not the biggest global health threat. I think I'm going to go into a little bit about exactly what this looks like. Again, I think you're feeling this on a day-to-day basis if you just live in the world today. And this is like a bigger picture, which sort of explains, what is climate change and what are all the health hazards that people can be exposed to, and what are the factors that make them vulnerable, what are the exposures, and then what are ultimately the health outcomes. Again, I think a lot of us actually know what this means in a much more tangible way. As an example, if you woke up and watched the news today or listened to the radio on the way in, you probably heard a little bit about the heat waves and some of the challenges that we're facing, both in Colorado, around the country, but also around the world. So this is an example. This is from today. This is literally from the New York Times today. So this is the flooding that we're seeing because of Hurricane Beryl's impact in Houston, Texas. And I want to point out, this was a hurricane that was downgraded to, I think, level 1 from level 5 by the time it actually hit landfall. So this is the kind of environment in which we have to provide medical care. This is the environment that medical students are having to get to their rotations in. This is the environment that anyone in administration has to work in. Do you have power? Do you have running water? Are you safe, right? So I'm going to make this a little bit interactive. I'd love if people can point their smartphones at this little QR code, and let's see what you know about these things. So what is the #1 cause of death in a flooding event? Okay, so it looks like a lot of people are thinking that the exposure to contaminated water is a very big public health and maybe the biggest public health issue associated with flooding. The reality, the right answer is it's drowning. It's still drowning. And it's drowning because of transportation injuries. So when people walk or drive in low level water, their risk of death increases by a lot. Okay, this is not unique to the developed, to low and middle income country settings. This is also true in high income settings. This is why on the news in the past week, you will see numerous references to Texas, their public health sort of campaign for a slogan called "Turn Around, Don't Drown," right? And I just want to like explain what this looks like in Colorado, because people think, oh, Colorado, we definitely have flooding in Colorado. We have lots of river networks, and we also have flash floods here. And I think last year, maybe I want to say the fall, we had kind of this crazy tornado issue, or like it was like tornadoes or hail or something like that. And we had these flash floods, and we're all in clinic at that time. I think I was in clinic, and then we had to sort of go into lockdown mode, I think 2 of the clinics. And Brian Bacek, I work at Lone Tree, he was there, and he has some of the disaster training, I think, and emergency preparedness training to be able to walk the staff through what to do in that setting. And, you know, patients drove into clinic that day, right? And then as soon as sort of the immediate emergency had dissipated, we sent everybody home via vehicle to drive under highway passes where there was low-lying water. So this is sort of the disconnect that I think we have to start to acknowledge and understand and then really engage with. Because how do we provide care if we are not safe as healthcare workers? How do we train trainees? How do we train these medical students if they're not safe in these settings? And what do we do? What is a climate resilient primary care clinic? How do we integrate that within the system? This is sort of, you know, the problem, I think, that I want to try and narrate to you guys, because I think if we're using these real life examples that we're actually going through, it's going to help. And also, again, there's a lot of primary care doctors in this room, and the vast majority of primary care doctors do not know the evidence base about what actually affects our mortality in these disaster settings, right? So keeping people off the road in disasters is one of the things that we can do to prevent death. And that is hopefully a takeaway point for folks listening, both remotely and here in the room. So I have another question for you guys. Rank the deadliest weather event from most deadly to least. Right. So I think we're doing a little bit better on this one. So extreme heat is the deadliest weather event in this country, but also probably globally. And that is something that is hard, I think, for us to think about, because heat is also kind of a silent killer. It really affects people in very insidious but also quick ways, and it can affect both the young. It can affect people who are, you know, middle-aged and healthy and, you know, working, and it can also affect people who are older. So let me tell you how I came to extreme heat. This is actually like one of the formative experiences for me in residency of why I started to make these impacts. I trained in New Hampshire. A lot of the nursing homes and assisted living facilities in New Hampshire do not have air conditioning because these buildings were built sometimes 50 years ago when we didn't need air conditioning in the winter. And over again, I would get requests from patients asking for a letter of medical necessity for air conditioning. My preceptors really were not able to help me answer this question. You know, do they have a medical need for this? And I think if you're climate informed, you start to come to the conclusion, absolutely. If you have chronic kidney disease, if you have almost any chronic medical disorder, you are at high risk for any number of heat-related illness outcomes. And, you know, actually that's one of the things that we can do, one, to be kinder and more compassionate to our patients in this changing environment, but also to help these long-term facilities adapt to heat waves that are now happening in New England. And so these are the sorts of, again, the purpose of this is really to help highlight, do we know the evidence base surrounding climate and health? What are the gaps in our knowledge, not just amongst the medical students and residents, but also amongst faculty and the rest of the department? So heat is, I think we're well into a year and a half of this being the hottest ever on record. This is the outlook, the climate and health outlook for June. So you can see how much of the country was really was likely to experience extreme heat above the average. There's some estimates that 100 million people or more Americans are probably exposed to extreme heat this summer, the past few weeks alone. And so this is really becoming increasingly a reason that people are landing in our emergency rooms and a reason for people to be admitted to our hospitals. So I want to highlight a few particularly disproportionately impacted groups. So this is outdoor workers, both here and abroad, as well as our first responders. So our first responders and colleagues are having to respond to climate-related disasters that are really unimaginable, I think, but also having to do it in extreme heat. So firefighters in particular are often going out in these environments. They're wearing these, protective gear that can exacerbate their heat exposure. And then they're having to work like really crazy hours too. Sometimes it's like 3-4 days nonstop. And what are the mental health impacts of this for the healthcare workforce, for the folks who have to respond and practice in this environment? This is an example from Arizona. They're starting to put together these protocols for rapid cooling. The emergency rooms in the health community in Arizona probably has reported some of the most tragic stories related to heat stress, like people getting pavement burns, that sort of thing. And so there are things that we can do as health systems, protocols that we can put into place to help deal with the problem once it gets there, but also prevent the problem, like cooling shelters and that sort of thing. And then these are wildfires not from the West Coast. This is a wildfire in Virginia in March of this year. So I think part of this is sort of understanding the environment truly has changed. It is changing, but it has also really drastically already changed. And this is the environment that, again, students are having to walk into their rotations for. Speaking of wildfires, I think I always like to talk about air pollution a little bit too. So here's another quiz for you guys. List the top 5 risk factors for premature global mortality. I think you just type it in. Yeah. Is it not showing up? Oh, there we go. Okay. All right. I think we still have some people typing stuff in. Okay. So this is actually updated, and I think some of you are kind of picking up on what I'm putting down, which is air pollution is probably the most underappreciated public health risk factor that most of our medical students are unaware of, most of our practicing physicians are unaware of. And so this is from a study that is sort of repeated every couple of years. This is from the Global Burden of Disease study from 2021. So if any of you have seen me present on this before, a couple of years ago, I would have been presenting 2019 data when air pollution was, I think, 4 or 5 on this list. The bottom line is for the past 2 decades, air pollution has been in the top 4 or 5 of this list and kind of goes up and down. But increasingly, the trend is that air pollution is becoming more and more of a public health burden and becoming more of a public health burden than tobacco, which many people in this department have spent their lifetime working on, right? And I really think this is a question that, like, any clinical provider should be able to answer, You know, like we should know what the evidence base is about what is actually killing us and what is actually causing us harm, and then spend our time and attention to address those upstream drivers, especially in family medicine. You'll notice that this is true also for children under 5, and these impacts are certainly, you know, more in low and middle income countries, but it is also a big problem here in the Front Range where we routinely have air quality issues. This is another way to look at this. So at the very least, air pollution is probably contributing to approximately 5 million deaths per year annually. It's probably closer to 8.1 million. And you can see when you're sort of ranking our priorities, what are we going to focus our attention on to address health equity? Air pollution is not often talked about, at least in my experience. But this, I think, really makes the point, like, are we practicing evidence-based medicine? You know, what does it mean when we start becoming climate informed? Does it help us become more evidence-based and strategic in our interventions? So yeah, and there's a wonderful editorial in New England Journal that says, do we really need another air pollution study? And the point that they make is absolutely, because the more we learn about it, the worse we find out it is for our health. This is talking about pollution more broadly, so not just air pollution. And again, more and more of the research, like the trend, is sort of pointing to the idea that pollution is really, at the very least, as bad of a problem as tobacco smoke, if not worse. And really this idea that, you know, this triad of pollution, climate change, and biodiversity loss are really the key public health issues of our time. And we have to start integrating that into our thinking and our decision-making when we put, in terms of when we think about where we're going to put our money, where we're going to put our time, where we're going to put our resources. Because if we don't think about the impacts of our decisions on these issues, we are just going to make the problem worse. And in fact, we are moving backwards on pollution globally rather than forwards. So this sort of highlights the equity issues, which, again, I think a lot of people sort of think about this in some way, shape, or form, but maybe haven't put it all together in like a picture like this. But when we produce pollution as a healthcare sector, when, you know, we have folks driving in on our highways, when we have industry, we have an oil and gas industry here in Colorado, as they produce that pollution affects some of our more, it disproportionately affects certain groups. A lot of those are low-income communities, Black and brown communities, older adults, and children. And I think I want to really highlight the impact on children because it's an exponential impact, and children of color, low-income children, have really a deeply unjust impact related to climate and health and environmental pollution that if we are being serious about our, you know, ambitions to address health equity, we have to look at the upstream driver of that inequity. And often it is environmental racism, as well as intergenerational inequity. And so trying to think about, you know, what can we do? And then I also like to say, don't forget about the impact on healthcare workers themselves. So that includes us. And then what's our impact? So this is from a study. It's a little bit older now, but it's probably the best one that we have. So we contribute the US healthcare sector. So all of our healthcare buildings and you know, ambulance fleets, et cetera, we contribute to about 8.5% of total US greenhouse gas emissions. So that's massive. It's not 1%, it's not 3%, it's 8.5%. In fact, if the US healthcare sector was a country, we would rank just behind the United Kingdom in terms of our environmental impact. So just by showing up to work and doing what we're doing, we have an environmental impact, right? As we're trying to take care of people. Well, do we have better outcomes for that cost? an impact? It turns out no. And again, I think this is not new for folks working in population health. So at the bottom here is total carbon dioxide equivalents, and at the top is life expectancy. So we are an outlier by far. And what we probably want to look like is France, which has a much lower carbon footprint, environmental footprint, and has a much higher life expectancy. So exactly what's the harm? Folks have tried to quantify this. The greenhouse gases, other air and water pollutants, this impacts public health. We think that this is equivalent to approximately 400,000 disability adjusted life years. In other words, this is similar in scale to the damages that come from preventable medical errors. So as a reminder, preventable medical errors drove the quality improvement movement in healthcare, right? And a lot of folks working in climate and health increasingly frame this as a quality issue. If while we are treating people for their heart attacks, we are producing enough pollution to cause these amounts of damages, it has to be part of our quality metrics to think about reducing our impact. And so it's really this sort of vicious cycle, right? We have disease, we provide healthcare services, those services produce pollution, that produces more disease. And so it's this, so how do we turn this vicious cycle into a virtuous one? And I think that's where I think we have a lot of opportunity for creativity. I think family medicine has a big role to play here in terms of our ability to sort of practice in a systems way and think about systems medicine. And I also want to highlight who else is doing this work. So this is from 2019. It's from the APHA. So numerous medical societies have highlighted that climate change is a health emergency. And I want to point out the word emergency, because how are we supposed to respond to an emergency, right? Rapid, coordinated solutions at scale. That is a disruption to the status quo that a lot of people might be uncomfortable with, right? This is like the COVID-19 pandemic, except we've known about this emergency and it's been intensifying since before I was born. Who else is engaged? The World Health Organization, National Academy of Medicine, the US Department of Health and Human Services, numerous medical societies. The AAFP is a founding member of the Medical Society Consortium on Climate and Health. Many people in this department contributed to the new position paper on climate change and environmental health. We were able to have the prior AAFP board president attend a United Nations Climate Summit for the first time. That's the first time any major leader of a medical society, American Medical Society, has been able to attend. There's also multiple AAFP articles on climate change and health for those that just want to learn more. And then the last thing I want to talk about is a lot of times we get to this point, everybody says, yes, this is a problem. Yes, it's an emergency. Yes, we should do something about it. But then people say, but it's politicized, right? Like climate change is politicized. Again, what does the evidence say? So this is a collaboration between George Mason and Yale, and they do these like periodic surveys on, who are trusted members of science about climate change and health. And you will see that your primary care doctor, we are routinely a trusted messenger of science amongst all registered voters. We sometimes, like every couple of years, we're like number 2, sometimes we're 3, that kind of thing. But routinely amongst the most conservative Republicans, we remain within the top 3. And so I think what this really speaks to is what I see as a big part of our job as family physicians and primary care doctors is we are truth tellers, right? It is our job to talk to people honestly about their health risks. And one of those things is conveying to our patients and our communities that air pollution is the number 2 risk factor for premature death. Heat is the deadliest killer. And please do not drive when there is flooding. Those are the sorts of things that we need to be able to communicate to our patients on a day-to-day basis. Those are the things we need to be able to encourage in our work culture so that we can stay safe. Those are the things that we need to be able to teach our trainees and residents. And even if you didn't want to do anything about this, let's say you were like, I'm good. I don't, you know, that's interesting, but I don't want to engage with this. It's too much. I think the changes are coming, right? There are regulatory changes that are inevitable at a national level, at a state level, at a city level, at an institutional level. So this is sort of an ongoing conversation. The Joint Commission is talking about a sustainable healthcare certificate. There is a push to make that, make mandatory environmental reporting happen. There were a lot of, I think the American Hospital Association wrote in, they had a bunch of, it was open for public comment, this proposal, and they were big, they were not a fan of that proposal. Interestingly, anybody who commented who was under 45 was pro mandatory environmental reporting. So when you're thinking about how do we train a department to practice in the future, this is, again, I think inevitable. And right now it's voluntary, but there are more and more conversations about how to make it mandatory, because as far as the military and the Department of Defense and the Department, you know, like all these other folks are concerned, climate change is a security risk, right? What good is a hospital if it does not have power and running water? Especially in a place like Texas or in parts of Colorado, it just is an oven, right? And so we need to be able to take care of people. This bottom initiative is from the Center for Medicaid and Medicare Services, which is, it helps folks understand how to get this certification. So the people who have volunteered to do this, they're essentially the leaders in this, and they will probably be the folks that define how to do this for the rest of the country in the next decade. Here in Colorado, we have state level legislation, and I want to point your attention to what our goals are by 2025. So 26% reduction in greenhouse gases across the state by next year, 50% reduction in the next 6 years. The University of Colorado is based in Colorado. So we have to help the state meet this goal. And the building across the street is the main reason that the university will not reach their goal, if there is one. So our health systems, our healthcare buildings are often given an exemption to meeting environmental and resilience metrics, right? In doing so, we are often the delta that needs to be fixed, right? But eventually we're gonna have to meet the metrics. And so what does climate smart primary care look like? What is climate smart and climate resilient primary care? This is undefined still. So to kind of put this into bigger context, this is from a colleague of ours who's a climate hero of mine, Courtney Howard. She's an ER doc who ran for office in Canada and is very engaged in planetary health. She works in Yellowknife. One of her big sort of triggers was wildfires in her region. And so all of us have a climate and health story, if not many, to tell. And all of us have reasons to care about this at a very deeply personal level. And so when you have that kind of trigger and you want to get engaged with this project, with this problem, often we think about, okay, I need to decrease maybe it's my personal carbon footprint, but I would say what we're often talking about in this context is how do we decrease the carbon footprint of our practices, of our office, of our workplace, of our department, right? Of our residency program, all of these sorts of things. And in doing so, we can help reduce the community's carbon footprint. And we're often tied to an anchor institution that can help facilitate this and ultimately help meet our national goals, our state level goals, which then helps change the story. It helps change policies, it helps change subsidies and investments. And so yeah, like this is an inevitable sort of outcome. It's a matter of where do we want to be? Do we want to lead and innovate on this, or do we want to respond to when these requirements are sort of, you're told you've now got to cut your emissions, figure it out. I want to just briefly touch on what we're doing here at CU. So as I said, I'm also housed in the School of Medicine's Climate and Health program. And broadly, our goals are to train the trainers, right? We want to train the leaders. And so we want to train credible, knowledgeable, effective clinical leaders on smart, patient-centric policies on planetary health. We want them to be able to advocate for climate smart and climate resilient policies, address deeply rooted environmental climate justice issues, and lead health systems in decarbonizing. How do we do this? I think this is what is interesting about the climate and health space. It's a fun place to work because we have to lean on intergenerational and transdisciplinary learning. There have been a couple of residents in this department who have probably been the experts on climate and health on numerous clinical teams over the past few years. And so we can really sort of promote a new vision for learning and academic innovation that is really exciting and collaborative, and ultimately promotes equity and inclusion. And then again, public health emergency, global public health emergency. So something that we really focus on is building a national and global community of practice so that we can really rapidly scale these solutions in a coordinated fashion. We're known best for our sort of thoughts on how to teach climate medicine. This is just a brief sort of picture of what this looks like in terms of thinking about competencies and, how do you go from being in your preclinical years to a practicing clinician. And at the end of the day, the vast majority of folks that need this education, it's not students and residents, it's practicing clinicians. So the continuing education space is really, really important. A vision that I would like to see is imagine you have your medical students by the end of their second year understand the problem of climate science and climate and health. By the time they graduate from medical school, they can talk to patients at the point of care at an individual level about climate change and health. They all understand duty of care standards in a disaster, because they're all going to have to practice in a disaster. And then as residents, they might also continue to focus on the patient care level, but then they might move on to thinking about, okay, what can I do? Can I work with my pharmacy colleagues? Can I work with my behavioral health colleagues to put together a quality improvement project on reducing our pharmaceutical waste, on reducing our, emissions from respiratory inhalers, that sort of thing. And then moving on to larger QI projects, and you're like more of a practicing clinician. Maybe you have more bandwidth to take on some of these other things. Maybe you're interested in policy work and you can actually work with legislators, that sort of thing. So I'll just briefly say, we definitely work with the university too, in terms of the School of Medicine, in terms of integrating climate and health education. We're pretty well known for our fellowship. We take 5 physicians a year. So one of them is from this department, starting in like 5 days. I think increasingly we're known for our work in continuing medical education. So not everybody can do a fellowship, but there are many people who are academic leaders or just clinical leaders in their settings. And not just physicians, but also our social worker colleagues, our behavioral health colleagues, our physical therapists, our the whole clinical team, they all want education and they want expertise on this. And so we have a professional development program where we take people through that. It's tuition based, but it sort of gives you a pretty good deep sort of knowledge base in this space. So I'll stop there. Happy to take questions. I know I gave you a very high level overview. Go ahead.
Do you mind talking a little bit about, as far as healthcare emissions, what France does differently or we do differently from France?
Yeah. So it's volume, right? We provide a lot of unnecessary care, and we have a system that incentivizes acute care. And so this is stuff that we've talked about for a long time, but we've never talked about the true cost of it. We talk about the social cost of carbon. This is sort of how it plays out in healthcare. So the OR is the most carbon intensive space. Treating people in the hospital uses way more emissions. Treating people in the community where they're at, that uses far less emissions. Telehealth is, again, this is an issue where this is a solution for many, many problems. And I think being able to think about how we can transition. The other thing that I would say is low and middle income countries often are doing a better job of transitioning to a sustainable healthcare system because they don't have those same resources. And so they're sort of showing us an example for how to do this. Thailand is a country that invested in primary care and now has increasingly recognized as a highly successful healthcare system because of their investment in primary care and keeping people out of the hospital.
Thanks, Bar. Outside of our roles in healthcare, how much of a difference can individuals and families make with stuff like plastic water bottles, just packaging?
Yeah. So I think that there's one thing, and I say this to like every doctor I work with, including surgeons, which is everybody can be a climate doctor. And that is by talking about eating more fruits and vegetables and beans and legumes, right? Eating a healthy diet is you are greener by default, you know? And I didn't say eat a vegan diet. I said eat a healthier diet. So if you're curious, look up a campaign called Beans is How. It's a global effort to double your consumption of beans within a year. And that will literally improve your health and help save the planet. So from an individual perspective, that is something that we can do and we can talk about. I think it's well within our purview as physicians and certainly as family physicians. You also can talk about the problem. So actually engaging with the climate and health issue and talk about it. And again, it's not as political as people think it is. And it's definitely not that political for Gen Z and younger. Talking about it and coming up with some of these solutions and talking to your legislators is a really important way that we can help, again, change the story.
Okay, and then we have a question online.
So the first question kind of ties into what you had to say about how the DFM and CU is involved in specifically advocacy. Do you have like specific examples of that advocacy? And the kind of follow-up is DFM part of the Denver Anchor Network?
I don't know what the Denver Anchor Network is, but yeah, I would say there are numerous examples from recent residency graduates, as well as like I routinely am testifying at the Colorado Legislative Assembly, you know, on behalf of certain bills or against certain bills. I specifically work with an organization called Healthy Air and Water Colorado. They have done a wonderful job of being able to like track the legislation in a coordinated way with the governor's office to be able to pull in health professionals. Our pediatric colleagues in the state are doing wonderful work with them as well, but they really make it very easy. I mean, I have been presenting in a different city, and I've just had them text me and I find a closet and I testify and the bill passed.
Thank you so much. The other one is another kind of follow-up question from what was asked, I think, by Amy before. But in terms of like what other people do differently for our medical impact, what are the largest sources of, you know, our footprint?
Yeah. So I'm happy to come back and give that talk. But yeah, understanding where our environmental footprint is a very good question. So all emissions and environmental footprinting is done this roughly the same way in all industries. And so it may seem unfair to you that a patient's commute to your clinic counts for your environmental footprint, but that's how we're calculating the environmental footprint for the steel factory as well. Right? So everybody's sort of doing this the same way, that we follow something called the greenhouse gas protocol. We follow a few different sort of protocols so we can accurately measure against each other. It is not a perfect system, but we do. And so roughly it's divided into three sort of categories, and it's called scope 1, scope 2, and scope 3. Scope 1 emissions are basically the emissions that you are immediately producing in the building itself. So if you have a diesel generator and you're burning that diesel, that counts towards your scope 1 emissions. And that's a big chunk of your emissions. The second sort of category is considered scope 2. And so that is all of your purchased electricity. So if you're purchasing from your, Excel, whoever, all of that is your scope 2. But the largest chunk of emissions comes from something called scope 3, and that's everything else. So you walk into the clinic, you had to drive there. Was that meeting necessary for you to be there in person, right? You then go into clinic and you put on some gloves. The gloves, where did they come from? The plastic, the transportation associated with getting the gloves to you. You use a disposable speculum on your pelvic exam. You could have used a, reusable one. There's a great life cycle analysis on that. Reusable pulse oximeters versus disposable ones. Like, there are sort of things that we know in terms of how we practice medicine, where there are orders of magnitudes of difference in certain choices. And so it makes more sense to do one versus the other. Sometimes it's as simple as an IV push versus a drip. Right. But roughly it's also the thing that I think we often forget about is the medications. So your medications, they produce emissions in production, transportation, and then also sometimes once they get to your facility, the medications themselves are sometimes more potent greenhouse gases than carbon dioxide. A really good example would be desflurane, anesthetic gas. Anyone been in an OR? We should not be using desflurane. You can use almost any other anesthetic gas, and it is far better for the environment. But all of those anesthetic gases are essentially greenhouse gases themselves. Nitrous oxide is one. So a lot of times there are wonderful alternatives to using nitrous oxide. But if you are going to use it, it often is leaking all over the place. So that's often an opportunity to make some improvements. And then respiratory inhalers. So when you type in albuterol in Epic, albuterol HFA pops up, which has a propellant, which is an anesthetic gas. In most other countries, they're switching to dry powdered inhalers because it doesn't have the propellant. And so as best we can, if we can make accurate asthma diagnoses, be responsible in our prescribing, really be stewards, right? And switch to DPIs whenever possible. If it's appropriate, we'd be reducing emissions.